the slide has moved forward. You see, even in an acute mental stress, you will find that there are a number on here, but then you have contribution to the perfusion, limitation, and ischemia. All these effects are there which increase the risk of cardiovascular disease. Now, in those patients who are centrally obese, you will find that there are certain changes which take place in the system, like production of the vascular toxic adipokinins, endothelial inflammatory response, and the production of leptin. They're all increased in those people who have central obesity. There is an endothelial dysfunction and insulin resistance, and this then results into an activation of the sympathetic. So all these factors which I'm referring to, diabetes, obesity, they are actually increasing the sympathetic nervous system. Diabetes and obesity, you will find that there is a much greater increase in the sympathetic activity than when they are existing alone. And normally they don't exist alone. It's a triad which is there. Another, just as a information, what I would just like to pass on is that those individuals who are obese and unfortunately contract COVID-19 and they are put on a ventilator, their prognosis is worse than those who have a body mass index which is normal. Now, when we look at the sympathetic nerve activity, we'll find that it is increased in those who are centrally obese. It is also there in peripherally obese, but it is least in those who are lean, who are thin. And also in smokers also, there is an increase in the heart rate and blood pressure, and that also actually augments the sympathetic nervous system. So smokers, diabetic, obese, all these individuals, hypertensives, they have an increased sympathetic activity, which causes all the problems to them. And whenever you have an increase, you'll find that it was seen in this experiment where the norepinephrine was higher in those who were smokers as compared to the ones who were sham smokers. So we have tried to understand what the sympathetic overdrive is, how it is affected by the different conditions, hypertension, diabetes, obesity, smoking. And now let us see what it does to blood pressure. And when we look at that, according to the Framingham study, this is very interesting that when you have a blood pressure which is less than 55 years, that is more of a diastolic blood pressure. And the blood pressure which is after 55 is more of a systolic hypertension. And the predictors of diastolic hypertension are young age, male sex, a high BMI at baseline, and increasing BMI. Now, in the elderly population, where you have isolated systolic hypertension, this is a little bit more difficult to treat because here you have an increased arterial stiffness. There's an aging of the arteries which you can't reverse. And in the diastolic hypertension, there's an increase in the peripheral resistance. So in the younger individuals, what the case I'm trying to build here is that since the younger individuals or the middle-aged patients, they have a sympathetic overdrive. So even if the guidelines do not recommend the use of beta blockers, we can make a case for that. And a very important case which I feel is that when we say that the beta blockers have no role in the treatment of hypertension or in the treatment of cardiovascular diseases, what we are doing is we are throwing the child out, the baby out with the bath water. And this should not be done because there are cases, there are instances where you can use beta blockers in the treatment of your patients with hypertension. And I think this we have to keep in mind. Now, when we look at the heart rate in our patients, we'll find that if the heart rate is low, they have actually a much better prognosis as compared to those who have a higher heart rate. So we need to actually control the heart rate, and all of us who are treating patients with hypertension and heart failure know that if in heart failure especially, we need to keep the heart rate down. That will actually reduce the incidence of events in them. That will also reduce the incidence of rehospitalization in these patients. And when we look at the risk of cardiovascular mortality at the different heart rates, you will find that when the heart rate is less, the incidence of coronary heart disease, cardiovascular disease, all cause mortality is reduced in comparison to when the heart rate goes up beyond 70. And at beyond 80, you will find that it is much more increased. There's an increased incidence of coronary heart disease, cardiovascular disease, and all-cause mortality in our patients. Similarly, we will see that there's an increased mortality risk with increased heart rate it was seen amongst the French men according to age, less than 55. The same thing was seen that if the heart rate is higher in these younger individuals, there is an increased relative risk of death, which can be seen in these individuals with higher heart rate. Similarly, there is a 3.8-fold increase in the risk of sudden death compared with the lowest heart rate quintiles. That is what was shown here in a group of patients, 7,000 patients in this age group who were followed for an average of 23 years. Now, also, if we look at the 5-year observational study to characterize the patients at high risk for death and cardiovascular complication, it is the same thing which is evident to us with the increase in the heart rate. So now that we know that the sympathetic overdrive results in hypertension, especially in the young and the middle-aged individuals, there is an evidence of that, and there's an evidence that if the heart rate is high, the incidence of cardiovascular events is higher. So what are the therapeutic options that are available to us? The options are a few of them, like for example, you can use verapamil or diltiazem, you can use beta blockers without the intrinsic sympathetic mimetic activity, like for example, bisoprolol, and you can then the heart rate control via the actions on the sympathetic overdrive, and then you have those a drug which acts on the funny channel, which inhibits it, ivabradine, which if you are not able to reduce the heart rate with the maximum use of beta blockers, then obviously you add that. However, with the non-dihydropyridine calcium channel blockers, the action is not related to the sympathetic overdrive, but by reducing the nerve conduction velocity and prolonging the depolarization. So it is different. It doesn't reduce the heart rate, but it has an effect upon the conduction velocity. That is what it does. But the beta blockers actually, they are able to suppress the sympathetic overactivity, and that is how they control the heart rate. Now, when you look at the different drug classes which are given here and the effects that we have on the peripheral sympathetic nervous system and on the cardiac sympathetic nervous system, we see out of them, I will not go into the details of the others, but with beta blockers, there is definite reduction with the peripheral sympathetic nervous system, and there's a marked reduction in the effects of the cardiac sympathetic nervous system. And this was in one of the studies which was shown that if you are treating when you look at the effects of 1 week of treatment with a losartan, with a sartan, not a losartan, but a sartan, 600 milligram per day versus placebo in patients with a normal blood pressure of mild hypertension, you would see that the percentage difference in the mean values after 1 week of treatment with placebo versus sartan, these were the effects which were seen on the heart rate and on the muscle sympathetic nerve activity and the plasma norepinephrine. There was an effect, but not very significant, because if you use sartans or ARBs, you will be actually suppressing the angiotensin, the renin-angiotensin aldosterone system, but the sympathetic activity which is increased there is not affected so much. Then If you look at the beta blockers in the treatment of hypertension associated with the sympathetic overdrive, we find that the beta blockers actually act at the entire cardiovascular continuum, from starting with the risk factors, atherosclerosis, coronary artery disease, infarction, arrhythmias as a result of the loss of muscle. It can result in sudden death. There's a remodeling which takes place, and the ventricular enlargement, congestive heart failure, and death. So beta blockers are used effectively in those patients post myocardial infarction. The benefit is the maximum which is seen there. It also has an effect upon remodeling there. And if you look at this, you will see that the beta 1 receptors actually at the myocardium, they increase the contractility in the heart rate, as I showed to you earlier on. There's an increase in myocardial just let me, I think the connection has been affected. I will just try to reconnect, and then I'll start the presentation again. Okay, we get back to it since we are on track again. So the beta 1 receptors at the in the myocardium, these are the effects here when they are stimulated, and the bronchial smooth muscle when they are, the beta 2 receptors are here, and in the blood vessels, the beta 2 receptors, and the kidney, as I said earlier on, it is the renin release. So when you have patients who are diabetic, who are obese, and who have insulin resistance, what you do is that with a beta 1 selective blockade, you are able to affect all this. And these effects of, as a result of all these changes, you are able to suppress the arrhythmias, the beta 1 stimulation induced cardiac and coronary damage. This also can be altered. The blood pressure, which goes up at night, and the non-dipping at night, this is also affected if you give them beta blockers. Ideally, if somebody is to be put on a beta blocker and has some dizziness, you can start it at night and then shift. And if the symptoms are gone, then he can be shifted in to once a day, and preferably in the morning. And when we compare in the UK PDS study, the ACE inhibitors and the beta blockers, we see that there's a 23% reduction in death from any cause in patients receiving a beta blocker. This is what was, the graph actually starts separating quite late, if you see here. Then in all the trials on beta blockers, people with a history of coronary heart disease, when they entered after an acute myocardial infarction, entry after a long-term coronary heart disease, and people with no history of coronary heart disease, you would see that the benefits are maximum here post-MI and in those with coronary heart disease. Now, these are the different kinds of beta blockers that you have. The beta 1 selectors are atenolol, metoprolol, bisoprolol, and the others here. And then you have those with the intrinsic sympathetic activity. We're not using them so often now, like the non-selective ones here and the others. By and large, when we look at the various recommendations from the societies and the recommendation from the European Society of Cardiology, we have all these groups of drugs which can be used and are suitable. And then as far as beta blockers are concerned, what I would say and add to this is that those who have an uncomplicated hypertension, maybe the beta blockers do not have a role in there, except in those cases who are the young patients, and you find there is a sympathetic overdrive in these individuals, that then you can use the beta blockers in them. Otherwise, it is the other groups of drugs which are more effective. And also, if there are patients who have a complicated hypertension and an uncontrolled hypertension, there you can use the beta blockers. So we must consider the beta blockers in younger people with evidence of increased sympathetic activity, as I said earlier on, and a recommendation from the Canadian Hypertension Society is that for individuals with diastolic or systolic hypertension, a beta blocker in patients who are less than 60 years of age, and it's a grade B recommendation that we have. So now let us come to uh, the, the drug that we were supposed to talk about, bisoprolol, in the treatment of hypertension associated with the sympathetic overdrive. By now, I think we have understood what a sympathetic overdrive does and how we can block it, and the different beta blockers that we have, and now the beta blocker that we wish to study in detail. When we talk about bisoprolol is indicated for the treatment of hypertension, for coronary artery disease, angina. We all have been using it for that purpose. In heart failure, very useful. There's no doubt about it. What is the pharmacology that we have about it? The absorption is more than 90%. These are the other characteristics of this drug. It is 50% eliminated through the kidney and 50% by hepatic metabolism to inactive metabolites. And, there's no dose adjustment which is necessary in mild to moderate liver or kidney impairment, and the daily dose to be limited to 10 milligram in terminally insufficiency in those patients with liver or kidney disease. And then if you look at the ratio of the inhibition that we see with the different beta blockers, there is the best beta selectivity is with bisoprolol. And also the affinity for the beta-1 receptor is maximum with bisoprolol as compared to the other beta blockers that we have been using. Now, what about the efficacy that we have in comparison with atenolol? There's definitely a better efficacy reduction in blood pressure, both in the daytime blood pressure and also at the nighttime blood pressure, which is very important because those who are not night dippers or who continue to have a blood pressure at night or increased blood pressure at night, as with atenolol, they have a worse prognosis. And then if you look at the response of the different drugs, bisoprolol, losartan, amlodipine, and hydrochlorothiazide, you will find that the reduction actually with bisoprolol is quite good, both in systolic and diastolic blood pressure, and also seen in the 24-hour ambulatory blood pressure response, which is actually the one which should be now used more often to evaluate the efficacy of these drugs. Now, when we compare it with nebivolol, you will find that it is comparable. The blood pressure reduction is comparable with it. And also, if you look at the middle-aged hypertensive men, and in this study, you'll find that the best results were with bisoprolol in comparison to the other, even the gold standard amlodipine that you see here. Then the success rate after 8 weeks of individually titrated treatment, when you compare bisoprolol with atenolol, you find bisoprolol is much better. It reduces it. And then it is in this study, especially what was seen was that in smokers, there was a much better reduction of blood pressure with bisoprolol as compared to atenolol. And the creatinine clearance with the bisoprolol and losartan is better as compared to losartan. The systolic blood pressure is better controlled with it, and the diastolic blood pressure, which obviously was shown in those individuals where the blood pressure was high in the less than 55 years age group patients. So what about the safety? It is very safe. It can be used in patients with chronic obstructive lung disease. There was not much of a problem with it, but obviously, if it does affect the lungs or it does cause any bronchoconstriction, then you would be reducing the dose of bisoprolol. And in asthmatic patients, it was used, and the airway resistance was not so much seen with bisoprolol as it was seen with atenolol. And then when you look at the different parameters as far as the the blood changes in cholesterol, triglycerides, glucose, HbA1c are seen. You would find that if you compare it with placebo, it is nearly the same. So it does not affect the metabolic profile as much as the other beta blockers. And then if you look at the long-term therapy with it, bisoprolol, the benefit of the change in plasma HDL is not so much. You can see this here. Maybe there's an effect with the other drugs like atenolol, with propranolol in the beginning, it falls down, may go up. But with bisoprolol, it nearly remains steady. It does not reduce the HDL so much. The effect upon the sexual activity is very important because patients then stop taking the drug if they have an erectile dysfunction. And the results with bisoprolol were much better as compared with amlodipine. So the safety also is there, the efficacy is there, and the side effect profile is much better as compared to the other beta blockers. So, dear colleagues, finally we come to the last two slides where we will just enumerate what the summary is, the take-home messages. The sympathetic overdrive we have seen is associated with the development of multiple cardiovascular risk factors and is the main cause of hypertension in young and middle-aged men. So here it is in this group of individuals who are hypertensive that the use of bisoprolol or beta blockers become quite evidence-based. And then you have the sympathetic overdrive, which leads to the elevated heart rate, and that increases the risk of cardiovascular mortality, particularly in middle-aged men with hypertension and or diabetes. And the adverse cardiovascular outcomes associated with this sympathetic overdrive result from the neural increase. We talked about it, norepinephrine, which then stimulates the beta-1 receptors in the heart and the kidneys, affecting the cardiac output and affecting the renin-angiotensin-aldosterone system. And the beta-1 blockade, after all these effects on the cardiovascular system and the renin-angiotensin-aldosterone system, beta-1 blockade helps to prevent the adverse effects of this sympathetic overdrive, which we have seen, and it could protect the heart at every stage of cardiovascular continuum, which we saw right from the risk factors going around to infarction, to arrhythmias, to heart remodeling, to heart failure, and to sudden death. It has an effect on the entire cardiovascular continuum. And the beta blockers are recommended in treatment guidelines for the initiation and maintenance of antihypertensive treatment in those selected group of patients who are the high-risk individuals who have complicated hypertension, who are uncontrolled, and the benefits of beta blockers in younger patients have been highlighted in this presentation. And bisoprolol is a highly beta-1 selective beta blocker. We saw that in comparison to the other beta blockers and is available in most of the countries in the world. Bisoprolol provides effective 24-hour blood pressure control. We saw that with the ambulatory blood pressure recordings that we did, and it has a once daily dosing. Then the treatment is a treatment of choice in young hypertensive patients with additional risk factors for sympathetic overdrive. And which are those additional risk factors? Those who are smokers and those who have who are diabetic, who are obese. All these individuals actually, they are the high-risk individuals, and there you can use these, you can use beta blocker, and you can use bisoprolol, which has a very high affinity for beta-1 receptors. So these are the patients who have the associated findings with hypertension, who are smokers, who don't quit smoking, who are overweight and obese, who are diabetic, and who have high levels of stress. So basically, what we are doing is that we are treating the sympathetic overdrive, which occurs in patients who have hypertension, who have increased heart rate, and we can then evaluate them that the reason for their hypertension This is what it is. In the younger individuals, especially those less than 55 who have more of diastolic hypertension, and then those individuals who are hypertensive and associated with that, they smoke, they are overweight, they're diabetic, they have high levels of stress. But important is also the non-pharmacological treatment aspect to it, because when you have that, you are able to reduce the blood pressure. You are also able to, if the patients quit smoking, they're benefited by it, then the weight is reduced, the incidence of diabetes in these individuals is reduced, and those who are diabetic and who then exercise regularly, who are physically active, they also get the benefits of it. The diet, a healthy lifestyle, a healthy diet is extremely important. And then methods like meditation, 5 times of prayer every day, with along with fasting. Like for example, the month that we are going through at the moment, where fasting, the benefit of fasting has been clearly shown even by science when we talk about autophagy, where if we have intermittent fasting, there is a rejuvenation or recycling of the debris or whatever is broken down in the body, that it rejuvenates the body, it recycles it. And there are benefits of autophagy, which science has shown, which was taught to us 1400 years ago. I thank you for your patient listening, and if there are any questions, I will be very happy to take them.